admitting.
Hi, everyone. Welcome, welcome, welcome. Oh, nice to see faces. I'm Chelsea Roff, and I'm here with Dr. Catherine Cottone and my friend and colleague Melanie, who's going to be helping us with the chat. And we're really honored and grateful and excited to share some of our findings from our recent systematic review of assisted death in eating disorders, which was published this last week, this last Wednesday in Frontiers in Psychiatry. We would love for you to drop in the chat where you are joining in the world if you're here live with us. And I know many of you may be watching somewhere in the future. So hello in the future if you're watching in the future. And we'll get started. Catherine and I are going to, we've got some slides to prepare just to, we hope that you'll, if you haven't already, that you will read the study, or if you have already, thank you. And we hope you've come with questions. We wanted to share a little bit more context and some kind of extra things you might not read in the study, or call out a few of the big points, and then move as quickly into questions as possible so that we can have a conversation. So with that, Catherine, I'm going to bring you to our first slide.
So we want to begin by acknowledging the reflexivity and give you the perspective from which we're each coming from. So I'll start. I'm a professor at the University of Buffalo. I typically research embodiment as it relates to eating disorders, prevention and intervention, things like self-regulation from and through the body. And then importantly, I am someone who has recovered from an eating disorder.
Yeah, and my similar to Catherine, I consider myself, if not in recovery, recovered from an eating disorder from about 19 years now. Relevant to this particular study, I was hospitalized with a very, very low BMI when I was 15, and spent over a year and a half in the hospital, and was told, multiple times that they didn't think I was going to make it. So I bring that experience and that lens to my work. And then also relevant to this, I work with people with eating disorders every day, and I have worked with people from inpatient down to residential and day treatment. So I carry those stories inside me, and it certainly affects how I see this work.
Oh, I should add, I'm also a psychologist that
Yeah.
treats eating disorders. Left that part out.
Yeah.
So thank you, Chelsea, for that reminder.
Thanks. Yeah, it made it to the study, which was the
Yeah.
important part. Okay, well, the other thing we wanted to start off is just by acknowledging the minefield of terms that are present in this conversation. And I call it a minefield because it actually makes it very difficult to have a clear conversation. One thing Catherine and I noticed in our research is we, you know, brought ourselves up to speed on not just the research in the United States and the United Kingdom, but also in the Netherlands and Belgium and Australia, in many countries in the world, is that everyone uses different terminologies. And I think it's important to name too that sometimes these terms are actually selected or rejected for the purpose of shaping public discussion. So, we saw that, we saw that quite a lot. We in our study really tried to step out of the kind of choosing terms to shape for public discussion, and wanted to be as specific as possible. And I think it's relevant to our conversation today. In academic literature, the term physician-assisted dying or physician-assisted death, or just assisted dying, assisted death, those terms are considered academically acceptable, but they're also very broad terms, and so they can be problematic for that reason. But they're useful because they're talking about all these different practices. In assisted dying, assisted death, there's really two kind of major practices, and there are others that are recognized, and that's euthanasia and assisted suicide. Euthanasia really is that has so many connotations and meanings to it because we associate it with involuntary euthanasia. You might even hear that word and think about euthanizing a pet. But at least in literal terms in academic literature, we're talking about a healthcare provider administering lethal or life-ending medications to a person at this time at their voluntary request, subject to safeguards. And when we're talking about assisted suicide, we're talking about a person self-taking those medications. And assisted dying or assisted death is a broad term that encompasses both of those. We're not using the term physician-assisted dying, physician-assisted, because increasingly physicians are not the only healthcare providers that are prescribing and administering drugs. So that has changed recently. So we're using kind of a terminology that's become more common. We're not using the term medical assistance in dying. I've gotten this question a lot since we published our studies. MAID is more, so you've in Australia, voluntary assisted death is a common term. In the US and Canada, MAID or medical assistance or medical aid in dying is more common. We're not using that because the problem with that term is it mixes up multiple types of assisted dying or assisted death. So it doesn't distinguish between euthanasia and assisted suicide. And it also doesn't make a very important distinction that's was important for our work, which is it doesn't distinguish between people who are taking lethal medications at end of life in the dying process versus those who are non-terminally ill. It just kind of puts them all in one space. The other issue with that term that's been raised by many researchers and advocates is that when we're talking about people with mental illness, and in this case, eating disorders, it can be a bit of a euphemism. So that is something we were aware of, and it's part of why we've selected to use these terms. You have to pick some terms to use in your paper. So we tried to go for those with that were at least the most specific to what we were talking about. And you'll hear in this presentation, if I'm using the word euthanasia, I'm talking about euthanasia in its literal application, and I'm often talking about it in Belgium or the Netherlands where that term is used. That's a jurisdiction-specific term. And if I'm using the word assisted suicide, it's because I'm talking about assisted suicide. Okay.
Oh, I thought this one's yours, right? Or no, it's mine. Okay, I'll do this. I'm going to go through this one. So the eligibility criteria encompass these general areas, and they vary from jurisdiction to jurisdiction. So the first one is this notion of a terminal condition, and that is required in United States, Australia, and New Zealand. And that terminal condition means that with reasonable certainty, the physician is able to predict that the patient is probably going to die within the next 6 to 12 months. And it varies from jurisdiction to jurisdiction. And there's issues there in that physicians can't very accurately always predict how long until someone will pass away. So this terminal condition is one of the criteria, and like the others, has some issues that we could discuss at length. Irremediable condition is a term that is also required and a criteria that's required in some of the jurisdictions as well. And so here it includes the Netherlands, Belgium, Luxembourg, Canada, and Spain. And this is often offered paired with this unbearable suffering term. So in the irremediable condition, it means that I don't believe that this condition will change or it won't respond to treatment. And so this person is either going to get worse or they're going to stay the same in a way that is pretty unbearable. And then voluntary request, that occurs in all jurisdictions that we've explored, all jurisdictions, I think, in general. And this is the person must have the mental capacity to be able to say, I voluntarily request this. And then there are other jurisdictions where this is not yet regulated, but it has been legalized. So they have yet to publish the specifics about how it's going to happen, but those are forthcoming. And then if you go to the next slide too.
You mentioned the only thing I'd mention here is Switzerland is kind of an outlier in these. So Switzerland assisted suicide has been legal since 1942, and the only criteria is that the person it's actually not even a physician. Typically, they've got nonprofit organizations in Switzerland that manage this process, but that the entity or the person involved doesn't have selfish motives. So that's an outlier. And I'll just also add to what Catherine said: the irremediable condition, we've got a whole table on this in the paper, which I welcome you, but it's the language around this is different in every country. Sometimes they use incurable, sometimes they say irremediable, sometimes they also say unbearable suffering. That's usually kind of tied up with one another. And one of the issues with all of these is just that they're not particularly well defined. So you've got a law that says these are safeguards, but when you dig into those, they're actually quite hard to implement in practice.
Yeah, and that was one of the challenges of the study was to come to an agreed upon, how are we going to define these concepts? And then when we saw them operationalized and really utilized in practice in the case studies, it was then right trying to find like how is this being practiced and how is it being defined and in what exact term under the law is it being utilized. And so it resulted, if you had time to read the paper, you'll remember this, but if you haven't had time yet, dig into the paper, because what we decided to do was to do it in two phases, where we talked in the beginning of the paper about all of this legal stuff, so you have a good understanding of the definitions, and then we went into the data, and then we reapplied the data to the legal and ethical understanding, so that you can really walk through the paper a bit like we walked through the process of the study and come to know, like we came to know these data. So I think you will find it kind of a journey, an enjoyable journey to read the paper. And so this is a map that Chelsea beautifully created that shows you what the last slide says, but in more of a, so those of you who are more of a graphic learner, you'll really appreciate this. And where you see the red around the boxes in those jurisdictions, that's where we currently know that assisted dying is being used for eating disorders. So this is the same slide, but color-coded in a map for you.
Yeah, and just speaking to that journey, because we'll get into this in the next slides. When Catherine and I started kind of digging into this systematic review, we of course started with the peer-reviewed literature, so the scientific literature, and went, how many are there cases of patients with eating disorders that have been euthanized or assisted in suicide in the peer-reviewed literature? And we knew from the peer-reviewed literature, that there were some in Belgium and the Netherlands and Oregon. And then we were able to identify, upon digging, that there had been a couple in Colorado and California, which I'll speak to as well. The final thing we wanted to mention around age and residency, or around eligibility criteria, and it was tricky to figure out how much to include in this article, but I think for those in North America, maybe less so in Canada, but especially in the US, fairly kind of new to the assisted dying legislation kind of conversation. But in, the Netherlands, Belgium, Luxembourg, Switzerland, these assisted death or assisted suicide or euthanasia have been legal for many years. Over 20 years in the Benelux countries, which is Netherlands, Belgium, and Luxembourg, and as I mentioned, in Switzerland since 1942. And you'll see this on the next slide, but initially laws tend to be fairly restrictive. They tend to, have very kind of rigorous, really say, well, we're only going to use it for people who are in the active dying process. And what we noticed is that over time, if you look at those laws, slowly you see amendments being passed that open it up to greater numbers of people. And I think, this is my own personal kind of reflection on that, and analysis on that, is we have in the West a concept of individual rights, and we have a concept of mental health parity, meaning that we try to, recognize that mental illness deserves the same care and treatment as physical illness. But those same concepts get applied to assisted dying and assisted death when it's in a healthcare system. So we say, well, if a person with cancer has access to euthanasia, then a person with a mental illness should have access to to euthanasia as well. That is how these legislative changes start happening over time. That's what I've observed. So in the Netherlands, Belgium, and Switzerland, and Colombia, where they don't have a lot of regulation yet because it's a fairly new law, assisted death is allowed for minors. In the Netherlands, between the ages of 12 and 16, you need parental consent, and 16 to 18, you don't need parental consent, but the parent must be involved in the process. And then, of course, 18 and up, you don't need parental consent. Belgium, like theoretically, it's actually involved at any age. It's allowed at any age, subject, they say, to safeguarding criteria. So the person, if it's a 10-year-old, a physician has to evaluate that 10-year-old and say, yes, this 10-year-old has mental capacity to terminate their life, which is, I would hope a big ask to make that judgment. The other big thing that we think is, and we wanted to mention age because it's relevant to eating disorders. While eating disorders affect people throughout the lifespan, often eating disorders start in adolescence. And one of the other things that I was concerned about as I dug further and further into this legislation is that there's many countries, and increasingly in the US, there's now 2 states that have lifted residency requirements. So that means that a person can travel to that jurisdiction, and even if they're not a resident in that jurisdiction, get euthanasia or assisted suicide. So while we might think of this as, well, it's not legal here yet. I live in the UK, it's not legal here. Because there are countries where it is legal, it's very complicated, because if you travel with a person to Dignitas in Switzerland, you may be subject to criminal prosecution here, but we're a globalized world and people are certainly traveling for this. They've colloquially called it suicide tourism. I will also just mention offhand that in the US, in Vermont and Oregon, MAID can be, and I'm again using jurisdiction-specific terminology here. This is not, I'm not picking and choosing words, but called MAID in the US, MAID can be prescribed by telehealth, meaning it can be prescribed virtually. It is not clear in current DEA and kind of law whether, if you prescribe MAID and that patient goes back to their home state, whether that's legal. It's not clear. There's a lot of gray area here. So I think one thing that was striking to Catherine and I is just what a wild west this whole kind of legal landscape is at the moment. Catherine, do you want to?
Yeah, so then we get to, and it's interesting because we're good partners in this, and that we had complementary interests and motivations. And one thing that's particularly interesting to me is the notion of voluntary request and mental capacity. And I started my career as a psychologist, initially as a school psychologist, and so I have extensive background in assessment, and I also grew up with a brother who has Down syndrome, which motivated me to be a school psychologist because I watched him being tested my whole childhood, and this experience of a psychologist coming in and figuring out what you know or do not know is fascinating to me. So when we look at what is a voluntary request, there are a few things that tend to be required. This concept's been around since after World War II and the development of the Nuremberg Code. So this includes the concept of intentionality, right? That the person really has the intention to do this and has these all overlap, but an understanding of that intention. And this is part of what they want and see for themselves. And this is a very authentic, it's coming from them. It's not coming from coercion or other pressures, that they have a full understanding of the process, the the treatment that's being prescribed, also alternative treatments, also how that applies to them, right? And their standing and what are the consequences of that. And then again, here, authenticity and independence can overlap in terms of thinking, is this my idea? Of concern is that eating disorders are complicated, they're frustrating. Family members can be burned out, practitioners burned out. And so this notion of inadvertent collateral coercion is there. And also that that how compliant is our patient, right? That if this is what the doctor is recommending, how independent can I be from the notion of what the doctor thinks is right for me or right for my diagnosis, right? Do I have this sense of autonomy within me to negotiate all of that? And am I negotiating it successfully? So is this a voluntary request is an incredibly huge question. Chelsea, is there anything
Yeah.
you'd like to add?
I just think the one thing I wanted to mention here, this was this figure was drawn from Beauchamp and Childress's work, which is, they've been around for decades and are bioethicists that have written a lot of very heavy and heavy meaning very cognitive and kind of thick material around the nature of autonomy and the nature of consent. So we drew from that and from Stostron and Juth, who I know, Catherine, you've really drawn from their work quite a lot. But one of the reasons we wanted to put it kind of combine some of those ideas and the work that's been done in this area is that we were seeing in the literature assisted suicide for eating disorders or euthanasia for eating disorders being presented as autonomy supportive care. And one of the questions that then arose to us, well, how are we defining autonomy? You know, that word is getting thrown around a lot in these papers. What does it mean to make an autonomous decision? How do we, how is that actually defined? So that is where, we had to pare down our original paper quite a lot. There was a paper of its own on the nature of autonomy, but that was part of what we wanted to introduce here in the beginning of the paper is this is what in healthcare ethics, this is how ethicists think about autonomy in healthcare and what it means to make a voluntary kind of decision in healthcare. And it's confusing a little bit because it overlaps with a related but a different concept. And I really want to highlight that, the understanding part of autonomy connects a lot to this, but they're not the same. And it relates to this concept of mental capacity, which you will see in every single assisted death law that is on the books. They will all say, subject to the patient or the person having mental capacity. But again, what we find is that mental capacity is not particularly well defined. And we have, and this is striking, if you take one thing home from this, I think, as especially those in the eating disorder world, there are no mental capacity assessment tools that have been validated for assisted death specifically, nor do we have assisted mental capacity tests that have been validated for eating disorder specifically. If you read this paper, the very few studies that have been done on whether healthcare providers are very good at assessing mental capacity in eating disorder patients, the answer is that they're not. And we also know from the very few studies that have been done on mental capacity in healthcare decisions, which is different from mental capacity in assisted suicide, which I'll mention in a moment. We know that many patients with eating disorders are found to have diminished capacity, to not even have the capacity to make treatment decisions, much less decisions about whether to terminate their life. There's a paper that cited, I'm going to mispronounce the name, so I won't try, but this found about a third of patients with anorexia in that study had diminished capacity. So I want to say a few things about mental capacity, especially for the eating disorder professionals that may be here, because this was, again, there's a learning curve. We hope to take you along this journey with us because Catherine and I had a learning curve here. Mental capacity, we get this idea from the criminal justice system. Does someone have mental capacity to stand trial when they have engaged in a crime. That is where we get our clinical conception of mental capacity. And there's a lot of literature on this, but the one thing that, everyone pretty much agrees on is that mental capacity is not a characteristic of a patient. It's something we look at in terms of a task-specific or a decision-specific assessment. So we wouldn't say a person lacks mental capacity generally. We would say they lack capacity to make this specific decision at this specific time. And so that's the decision specific one. I'm going to skip you down to the third one here in the table. That's important because mental capacity is understood as relative to risk, meaning decisions that involve greater risk to life require higher evidence of mental capacity. We need to be really sure that this person has full capacity to make this decision. We need more evidence. And there are many researchers who believe that it also requires higher degree of capacity, meaning this person might actually need to have more mental capacity to make a decision that would result in the termination of their life.
And then I want to
And
jump in here too.
yes.
What's concerning specific to eating disorders is that individuals who are clinically struggling with eating disorders often are pretty good at appearing what I call like apparently capable of understanding, right? They have apparent mental capacity. When we look at it's the MACCAT, like the exam that is used in some cases for assessing mental capacity, there's 4 criteria of understanding, appreciating, reasoning, choice that echo back to the previous slide. A few of those require a mere paraphrasing of the understanding. Like, can you tell me about your disorder? Tell me how you understand your disorder. Tell me about the treatment. And so a patient can paraphrase nearly all of the answers and then pass the test, right? Without truly understanding. And again, this will be our last slide, but the notion of really what is at risk here. They can have a pathological misunderstanding of what is happening, but still pass the test, so to speak. While Chelsea talks about capacity relative to risk, we don't have the tools to even just figure that out. Do they have the capacity relevant to a risk as high as end of life decisions?
Yeah. And I'll say also, I think I feel like I've hammered this point home in our paper. I probably said it multiple times. It comes across repetitively, but the cost of making a mistake here is the end of a person's life. The cost of getting it wrong is that person dying potentially prematurely. So that is part of why the evidence needs to be, the threshold for evidence for mental capacity needs to be really high. And it's part of why, as researchers, as clinicians, as people with lived experience, we're very alarmed that this is happening, given there are no standardized assessments. This relies entirely on clinical judgment. And laws do not require that an eating disorder psychiatrist be the one to assess mental capacity. They don't even require that a psychiatrist be the one to assess mental capacity. So
or a psychologist.
Or a psychologist. Yeah. Briefly, I'll just mention as well that mental capacity, especially in mental illness, can be variable, meaning if a person has engaged in very severe eating disorder behaviors one day, they may have not as many cognitive faculties available to them, which makes it very difficult and complex to assess mental capacity. So you can have somebody has more capacity on one day and less the next. And then also, I think this is really important in the conversation around autonomy, which just keeps coming up over and over again. We need to support autonomy, and if a person says they want to die, we need to. Mental capacity exists on a continuum. So it's not like they have it, we have to kind of make, in an assisted death assessment, they're going to make a yes/no decision. It will be binary. But in reality, we can recognize that a person has diminished capacity, meaning that they may be able to make some decisions, but not others. So to give you a specific example, a person with an eating disorder who's in treatment may have the right to refuse a tranquilizer, right? We can affirm their autonomy and affirm that they have the capacity to direct their body, and then also say, but we don't, that the bar for choosing to end your life with lethal medications is a lot higher. So we can recognize that they may have diminished capacity and have the ability to make healthcare decisions in some areas, but not others.
That's a great example. So this slide here shows us how there's over time, and I don't think you can see my cursor. I'm talking as if you all can see my cursor. But if you look over here, there's the jurisdiction here on the left, right? And then the date at the bottom. So we see Switzerland, as Chelsea talked about earlier, in 1942, and then we jump into the 90s and we see Oregon, and then the expansion of the laws over time. So each and all the ones here on this chart, you can see that except for Switzerland, because it was so broad to begin with, there was no need for expansion. But that so here in Belgium, mental illness in minors allowed over time. Here in Netherlands, so allowed for infants, mental illness allowed for couples, allowed for dementia with advanced directives. And so in each case, the laws have expanded in those jurisdictions over time.
Okay, so we're getting into the methodology here, and I will tell. This was the one thing in the paper that I really wanted to communicate, but we just couldn't figure out how to communicate it. So I'm taking this opportunity to do so. When I've been speaking to people about it, I've been describing it as we found 60 cases. We found at least 60 cases, because we can't confirm whether there were more in a few of them. But what I say is most of the data was in a black box. We couldn't even, most of the cases were not available for public scrutiny, so I couldn't confirm or rule out whether there were eating disorder cases there. And I just want to take you through in each country what that looked like. In the Netherlands, there's been 77,224 total euthanasia cases between 2008 and 2023. And the Netherlands is actually one of the few countries that is pretty good about monitoring the number of psychiatric cases. So in that time, there's been 904 psychiatric cases, and I'm annoyed that I can't see my notes, but I think I'm remembering correctly that from 2008 to 2023, psychiatric cases were something like 0.06 or 0.08%, so a very small number of the total euthanasia cases per year. And every year they've increased, and so it's now closer to about 1.5% of the total cases. So the psychiatric cases as a percentage of the whole are increasing every year. The Netherlands is interesting. In some ways, I'm so grateful to the Netherlands, because they, while we found the most cases there, they actually published some cases you can actually look at. So of these 77,224 cases, just over about 1,100 of them are published as case reports, meaning qualitative case reports. So they describe the patient and their circumstances and what led to euthanasia and how the assessment was done, which is a gold mine for researchers like Catherine and I. So of those 77,000, about 1,100 of them are published as qualitative studies, and most of those are actually not most of them, a large number of them, 198, were cases involving patients with psychiatric illness. So 904 cases of psychiatric euthanasia in the country since 2008. 198 of those 94 have been published as qualitative reports, which means that 706 of them we couldn't even look at. So I hope that makes sense. We could look at 198 of them and say, was there an eating disorder? Was there not an eating disorder? But in 78% of the psychiatric cases, we couldn't confirm or rule it out. So when people say, oh, well, there were only 60, I mean, one person is too many, but we couldn't look at most of the data. Sorry, I'm moving this around. In Belgium, we had a similar thing happening. So in Belgium, there's been 30,504 total euthanasia deaths since 2004. Belgium is different than the Netherlands. They don't publish qualitative kind of full case reports. They publish biennial, meaning every 2 years, kind of quantitative reports that sometimes include qualitative data. So meaning, information about the patient and their diagnosis. We reviewed 10 of those reports because they're published every 2 years. I'm having to do this off the top of my head because I can't see the notes. And we were only able to find confirm or rule out eating disorders in 3 of those 10 reports. So in 7 of the reports that we looked at, we could not confirm or rule out patients with eating disorders. So of those 3 reports that we could identify the psychiatric diagnosis, there were 214 psychiatric cases that named a psychiatric diagnosis, meaning 184 or 46% we couldn't confirm or rule out eating disorders. And I will say also just briefly about Belgium, you see that same kind of slow rate of increase in Belgium on mental illness, except fairly recently it's leveled. And that's because Belgium uniquely has decided to require that patients with psychiatric illness, they're supposed to undergo all types of evidence-based treatment before they can be approved for euthanasia, which has slowed cases in Belgium. I don't have Luxembourg up, but we checked Luxembourg, and mental illness is legally, you can request euthanasia for mental illness in Luxembourg. There have been no cases according to the Luxembourg report. So great safeguarding, it's legal there, and there have been no cases as I understand it. Then we get to the United States. So the United States uniquely, we found very little reporting. We reviewed 70 odd reports in the US in the jurisdictions where it's legal. That encompassed, at the time that we were doing the review, about 11,983 made prescriptions. And I'll say something about that in a moment. It's closer to 13,000 now. I went and looked at this data today just to refresh my memory because some of the new reports have come out. But in the US, some of the states track the number of prescriptions that have been made. And some of them also track deaths. So deaths resulting from MAID. So it's very difficult to discern how many deaths there have actually been. And it's also a bit concerning that we may have lethal medications floating around in the community that have or have not been taken. There's no follow-up of these prescriptions, which has to be a public safety issue. None of the states in the US report on psychiatric conditions, presumably because the US requires a terminal condition to be prescribed MAID. So you look at that and go, well, it's concerning, but I think psychiatric conditions are not typically considered terminal conditions, which may be why it's not included in reports. And I will say the Netherlands and Belgium, they only report on psychiatric conditions when a patient is requesting MAID for the purpose of a psychiatric condition, when that's the sole reason they are requesting MAID. They do not report on psychiatric conditions for the 11,000, or however many it was, I need to look back at those slides, but for the people that are requesting MAID for other reasons that are presumably non-psychiatric, we don't know anything about their psychiatric conditions. We don't know whether they also had an eating disorder, were depressed, etc. Switzerland, I just put this on here to demonstrative purposes. Switzerland has had assisted suicide is what it's called in Switzerland. It's been legal again since the 40s, since just after World War II, and we have the least reporting in Switzerland. I can't identify the number of cases that have happened there because the Swiss Federal Statistic Office didn't start actually documenting on death certificates assisted suicide as a category until 2011. There are no annual reports. There have been some studies done, and they'll look at like this year to this year, but it's very hard to get a full picture. And there's very little reporting there's no reporting requirements for psychiatric conditions. And we reviewed the studies that were done in Switzerland, and there's no breakdown of psychiatric diagnosis for those who have requested assisted suicide for psychiatric conditions. This is concerning because almost half of people who are receiving assisted suicide in Switzerland are foreigners. They're coming from out of the country. So that is a real concern, that there's so little oversight and public scrutiny for, again, researchers. And mental health conditions are, you can request assisted suicide for a mental health condition. So that was concerning as well. And then I just, the takeaway from all of that is the omission of psychiatric diagnoses from these public health data is a public safety concern. We have no way of monitoring this as researchers, of doing studies on it. I mean, again, I'm grateful to the Netherlands, to Belgium. Canada publishes some annual reports, and there's limited data there, but the kind of data we would need to go, how many people with who have requested assisted suicide or euthanasia have depression, with that data is not available. We don't have that data available. How many of them have personality disorders? That data is not available. How many of them have eating disorders? That data is not available. Okay, Catherine. Oh, this one's mine as well. Sorry.
Yeah.
Okay, briefly. This is a slightly overwhelming looking figure, which reflects about
That's
3
why
months
it's
of my
Chelsea's
life.
slide.
This reflects about 3 months of my life. But up at the top, the color coding is done for a purpose. All of the gray are countries, so you don't have to worry too much. The red are peer-reviewed case studies that come from the scientific literature, and the blue are government case reports. And this just tracks, in each of these countries. So just a note, we looked in Belgium, Luxembourg, and the Netherlands because because psychiatric euthanasia is legal for psychiatric conditions. We were going to look in Switzerland, but there's no government reports available. So that's not on here. And then we looked in the United States because we knew that there had been cases of patients with eating disorders reported. So we thought, okay, we'll just make sure to look at the data. So really what you need to know here is, in this whole process, we were able to identify about 60 unique patients with eating disorders who received assisted suicide or euthanasia. And I say about because in Colorado, which is where you see the annual report, one patient with ED here at the far left, not in Colorado, in Oregon, there was an annual report that made a mention of anorexia as a, quote, other illness. So it says 7 people with other illnesses died of this through MAID in, I think it was 2021. And there's an asterisk at the bottom that says, other illnesses may include, and anorexia is mentioned. It is not clear how many of those 7 had anorexia. It also made me go, other illnesses. How many of the other 77 reports have an other illnesses category? And almost all of them have an other illnesses category. And almost none of them tell you what's in the other illnesses category. And there is a meaningful, substantial number of people that have received MAID prescriptions for, quote, other illnesses. So that is why we say about 60, could be more than 60 that's represented. Colorado was really lovely, actually. The Vital Statistics program in Colorado was, I don't know how this happened. In Colorado, I contacted Colorado because I was aware that in the peer-reviewed literature, there was a case of 2 patients that had been prescribed MAID for an eating disorder. So I said, hey, I know this is in the peer-reviewed literature. There's nothing in your annual report that mentions an eating disorder. What's going on here? What's with the disparity? And I didn't say it that way, of course, but I wanted to understand that disparity. And Colorado was able to confirm that anorexia has been reported as a reason MAID was prescribed in previous years. They could not tell me how many cases. And they were able to confirm that it was represented in the, quote, other illnesses category. the reason they could not tell me how many is because when it's low numbers and they won't tell me exactly how many, they're concerned about patient anonymity. So if you know, I'm not quite sure why that, kind of holds up, but that's what it is. The official I spoke to was also helpful in flagging that in the past 3 years, they've seen a marked increase in MAID prescriptions being written for something called severe protein calorie malnutrition. He could not confirm because he does not know whether that was, another word for starvation related to an eating disorder or if it was something else. And he unfortunately could not confirm the age of those patients, which might have helped us a bit. So that's where we are with that. But what we got to the, that's kind of how we got 60. And then if you look at these light gray boxes here at the bottom, these are the cases where we had descriptive case reports. And this gets really to the kind of heart of our study where we wanted to go, okay, we've got a descriptive case report. What were the medical justifications that were used to prescribe lethal medications to these patients with eating disorders? How was that justified medically? So we looked at those 19 case reports with qualitative data and we coded them line by line for a long time, for hours and days that we and coded them line by line to try to extract what were the justifications that were used here. And then what Catherine and I did is looked at the literature and went, is there evidence? Are these justifications supported by current scientific understanding?
So here are characteristics. Notably, 100% of the cases we reviewed were women. 64% were under the age of 40. So the notion that these are, when we talk about end of life, that is somebody who's had a typical lifespan life, that these are young women, right? At least 64% are relatively young women. The type of eating disorder, 63% with anorexia nervosa, and then 63% and 68% underweight and malnourished, which has implications for mental capacity. Over on the right, you'll see the other symptoms that are here, including suicidal thoughts, multiple suicidal attempts, co-occurring depressive symptoms and anxiety, trauma symptoms, and then we put the other symptoms here, including physical disability, self-injury, psychotic symptoms. And then the next slide. And then we also noted that it was 95% of patients had multiple psychiatric diagnoses. So of course, 100% were diagnosed with eating disorders, 7% PTSD. We have 52% with depressive disorders, OCD, you go down autistic spectrum disorder. So we're talking about patients with really a complicated psychiatric history and multiple issues with their emotional and cognitive functioning. Okay, the next slide. And then you were going to go through this slide, right?
Yeah. So I understand how it does that. It's exciting. It wants to move on. We like I said, we extracted, we call it in research extracted, but we coded these 19 case reports to identify what were the clinical rationales or the medical reasons that were used. And we identified really 3 major domains that were used. So there were 18 rationales within those 3 domains. And, we used the legal kind of framework, of course, as a guide here. So unsurprisingly, the rationales fit into, the person has a terminal condition or a terminal prognosis. The person has an incurable or an irremediable condition, meaning, the eating disorder is incurable and the person is not going to get better. There's no prospect for improvement. And the person is making a voluntary request, or this is an autonomous decision. And here you can see those broken down one by one. So on the left, we have the irremediability domain. And here, 95% of these cases stated this person has unbearable suffering. And I'll just note that there's no objective way for a physician to measure unbearable suffering. And it often got tied in with their suffering is unbearable, and thus there is no prospect for improvement. Concerningly for Catherine and I, because we've done quite a lot on the concept of severe and enduring eating disorder or severe and enduring anorexia, you saw that language show up in almost half of cases. So they were using what is a fairly, still theoretical clinical category in the eating disorder research. Severe and enduring eating disorder, severe and enduring anorexia. This is not a diagnostic category recognized by the DSM or the ICD, but we saw it used in these case reports as a justification, as a way of saying, see, this person's condition is irremediable. They have chronic anorexia. They have a severe and chronic form of the illness. And we have not in eating disorder research laid out that there is such a form of the illness. And that's a burgeoning area of research. There may in fact be, we just don't have that evidence yet. I don't want to spend too much time on this. It's in the paper, but we'll go through a few of these. The other big domain I think to mention here is the terminal domain. This was very low because notably only the US cases framed eating disorders as a terminal condition. And I think there's been so much focus in the eating disorder world on terminal anorexia. We have to get rid of this term. Notably, there are multiple places in the world that are euthanizing people with eating disorders without the concept of terminal anorexia. They don't need that. So I think that's really important to understand. In the US, eating disorders were framed as a terminal condition because it's the legal eligibility criteria. You don't see that framing in any other place in the world. You see them framed as an irremediable condition in those parts of the world because those are the legal eligibility criteria. And then you saw some fairly strong statements that the person has decision-making capacity, or the person's wish to die is well considered. But again, we do not have standardized assessments or any validated assessments in eating disorders. So it was not clear how those rationales had been arrived at.
Do you want to go over the other notable features?
Sure. Just a few things here that really didn't fit into these big clinical rationales, but were notable. One of the big ones I'll mention, it's here toward the bottom, is that in 42% of the cases, previous physicians had rejected or refused the patient's request, and that was mentioned. It was almost never mentioned why. It was just mentioned that it had happened. Often the physician that had rejected or refused the patient's request was the patient's physician. It was someone with familiarity of that person. In the Netherlands, Switzerland, Belgium, there are euthanasia centers. And so if a person is initially rejected, they can go and go to a specialized euthanasia center. I acknowledge that, people may say, well, maybe the physician had moral or religious issues. That is a possibility. But it's also a possibility, I don't know why I keep doing that. It's also a possibility that the physician was concerned about whether the person met the criteria. Another big one, 68% of these patients, unsurprisingly, but also kind of shockingly, were underweight or malnourished when the request was granted. Having been severely malnourished and, underweight myself, I can say it absolutely has an impact on your cognitive functioning and your mental capacity. And we go into some of that research in the paper. Severe malnutrition leads to brain atrophy. It leads to cognitive impairments. It leads to anhedonia, alterations in emotional processing. So that was a significant concern.
I could also do a shout out for Patricia
Oh,
Westmoreland's book,
excellent.
Tipping the Scales, Ethical Decisions in Eating Disorders, and Elzacker and McKinney's chapter on mental capacity and anorexia that I hold by my side here as a great review that you can refer to on these issues.
I will also, in that book, Mark Conrad and Anne Hansen's chapter on assisted dying and eating disorders is excellent, and it was a wonderful resource to us in the writing of this paper. Um, as are many of the chapters in that book. There's one on mental capacity as well. So I will leave this to you, but those are two I just wanted to call out. And then Catherine, I'll go to you here.
So here, just going through a few things and we'll be all set. 47% of cases suggested the patient had severe and chronic form of the illness, which Chelsea covered our concerns with that. So the terms were used in this pseudo-diagnostic capacity as if they were legitimate clinical categories. And it's important to think about the power dynamics with physician to patient. And someone's telling you that you have a disorder that isn't even, hasn't been agreed on by researchers or clinicians or professional organizations. And you're being told you have that. And that one of the characteristics of this is it's severe and enduring. And what that can do just in terms of a kind of a self-fulfilling prophecy or my diagnosis leading my understanding of self, right? And then we wonder about our understanding and this notion of my own autonomy. And is this a subtle coercion, right? That maybe not be happening intentionally, but what's happening when someone tells me I have a disorder that isn't even an official disorder. So of concern, this pseudo-diagnostic process.
And
Now,
I would add that, there's exceptional research happening in the area of severe and enduring eating disorders or severe, even if we don't love those terms, the research happening there is valuable. We're trying to, these are researchers who are trying to understand, do patients have different needs after they've had an eating disorder for 5 years, 7 years, 9 years, after they've been through multiple, but these are not diagnostic categories that should be used in clinical practice. They're actively being researched. They lack an agreed upon operational definition. We can't be diagnosing people with this because we don't even have an agreed upon definition of whether it's, the person's had an eating disorder for 3 years or 7 years, or,
right.
the person's had previous experience. So and as Catherine said, there's an impact of that diagnosis on that person's psyche.
Thank you. That was a good add because exactly like that research should continue and perhaps we need to come to an understanding, but we currently don't have one now. Here, the patient was diagnosed with chronic PTSD, chronic anorexia, and recurrent depressive episodes. Right,
So
we'll do
that's
that
an
next.
example quote.
Yeah. From the cases, 42% described the condition as treatment resistant. I don't know. There's
This
so much
one,
there. Yeah.
This I could say so much on this, but there were so many similar to the concept of severe and enduring eating disorder. The concept of treatment resistance has no agreed upon definition in the literature. It is defined in so many wildly different ways, just completely different in every single paper. And yet this term was used to say this person is treatment resistant and thus they have an irremediable condition. So this is the issues with these is we look at the clinical rationale and then you dig into it and it just crumbles in your hand because there's no operational definition and there's certainly no research to say that a person that is treatment resistant will never get better. That research has not been done and we can't even define treatment resistant in the literature.
Perhaps when I think about the process of going through and reading all these cases, I think that was one of the most difficult parts was that to have in many cases a committee and people help to make this decision. And then as we dug into the rationales, that I love the image of it just disintegrating in your hand because it was just like trying to hold sand or water. There ended up being nothing underneath it that was a solid foundation, and that was pretty difficult to be with on a day-to-day with these data. The patient's inability and unwillingness to live was assessed by the doctor as persistent and treatment resistant. So it's another quote from a case.
Example quote. Yeah.
The
Uh,
definition of treatment resistance vary widely. Go
and
ahead.
it has no prognostic utility, meaning you cannot determine a person's prognosis based on that term.
Despite the patient's relatively young age, there was already a lengthy treatment history with a notable downward spiral over recent years. Treatment was essentially impossible. And again, I mean, this paper probably will be a book because every time, but you get each one of these you dig into, and it's like, can you say that? Can we say
Yeah.
that, right? And can we say that with an empirical foundation? And we can't. We can't say
Yeah.
that right now.
So this I'll just speak to. There's an entire section in our clinical rationales where many of the cases basically said that because the person has had an illness for a long time, they are unlikely to get better. So this is where we say can chronicity, meaning length of illness, predict likelihood to recover? And the answer is no. We do not have that research. And in fact, the research that we have shows that the longer a person has been ill, if you look at the longitudinal studies, the longer we follow people up, the more people get better. So there's several studies there. So in some cases, in chronicity as a predictor of duration, or chronicity as a predictor of recovery is one of those. Not only does the research not back this idea up that because the person has had an illness for a long time and because they've relapsed, they're unlikely to ever get better. Not only does it not back that up, but it actually directly contradicts that. Our research actually contradicts that. And obviously there's lots of studies out. There's multiple studies out there. And we need a lot more research, but that was just heartbreaking to see, because actually the nature of this illness is that it's often prolonged. I don't meet very many people that have had an eating disorder for fewer than 3 years. Most of my clients struggle for longer than that. And most of them endure multiple relapses before recovery. So I was heartbroken to see this. I was like, find me a person with an eating disorder that has not had a long illness with multiple relapses.
No, we have an RCT we did using Chelsea's program that will be out soon, we hope. But that most of the people participating had been sick for a long time, and we showed
More than
significant
10
results.
years.
Yes,
Yeah.
with really critical outcomes, including overall eating disorder scores on the EDEQ. So another one, treatment. So speaks to the multiple diagnoses too, but treatment aimed at autism spectrum disorder was not used because it was not the biggest problem, because autism can't be treated in a therapeutic sense. So this was one of the case quotes, or part of the rationale.
There were two cases in which we saw treatment for autism kind of explicitly dismissed by in the case. And this was interesting because there's actually been some great research in the UK on the development of treatment pathways for people who are neurodivergent, recognizing that people with eating disorders who are also neurodivergent, not only can they benefit from treatment, but they have particular needs in treatment. So this speaks to the fact that we were seeing, to me, this looks stigmatizing. That is not my researcher hat. That is my personal, evaluation. But there was another case where a person with autism and a co-occurring eating disorder was described as unlikely to benefit from therapy because they lacked mentalizing capacity, and that kind of language to me, is certainly not in alignment with the research that's come out on treatment for autism and eating disorders, and from a lived experience perspective, can be quite stigmatizing. And to see that those justifications were used to justify a person's death is even more concerning.
Right, and I would think maybe disqualifying. Okay,
Yeah.
and then so then the last couple slides, we're almost done. So who's asking? Right, 89% of these cases, and I had to keep reminding myself that these people were already dead. That I was like, oh, I don't know, it must be the therapist in me was gonna, switch things around, but they had already passed. 89% showed depressive symptoms, which we know, and again, somebody asked what book, and so we can send out information. Tipping the Scales, Patricia Westmoreland. but there's a whole understanding of malnutrition and restriction. It almost simultaneously goes with depression because you can't create many of the neurotransmitters without nutrients, right? And so you're already serotonin deficit, among other things. 52% diagnosed with depression, 47% had trauma, 37% diagnosed with PTSD. And so the next slide is a quote. So this is patient case 2015-89. And so I read through this patient's case today just to remember the case. Viewed her life as meaningless and realized that despite her continuous struggle, there was no prospect of improving her situation. She was tired of fighting. This person was diagnosed with anorexia, major depressive disorder, substance use disorder, and personality disorder non-specified. She was framed as treatment resistant. It said that her wish to die was not mental illness. I don't know how that could be. Competency was emphasized. The clinician explicitly rejected available treatment for this patient. Patient case 2015-89, if you want to look it up. According to prevailing medical opinion, this person would not recover. The patient was currently receiving palliative care too. So this person was already being helped for her suffering. At the time of the request had now been free of alcohol for 1 month, which to me shows that this person was responding to the support and treatment. So this patient to me really summed up my experience of working with the data, my experience of working with these issues. So again, patient 2015-89, and she's gone.
Catherine, do you want to end there and go to questions? Or do you want to?
Yeah.
Yeah.
Yeah. Oh, well, we do have my diagram. I think they should see it. It took me 3 months.
We fought to keep this diagram in the paper.
This took me 3 months to get to, but we have eating disorder psychopathology, and when it's less severe, you have access to your own desires that are based on your personal values and intentions. You have more access to your true autonomy, right? And then when we're over here where we're really sick, and the eating disorders influences there, the influence of starvation and the influence of isolation and the influence of co-occurring mental illness is there, we don't have access to our own autonomy. It's occluded by the pathological, and they call them psychopathological values and suffering, right? That are getting in the way. So the patient request lies here in the middle of this, and this concept of decisional authenticity. And Chelsea, cite the authors for me. I'll say the name wrong.
It's yeah, these aren't just words on a page. This is if you do look at the study, it's Sjostrom and Juth that has done a lot of work on the psychopathological values. There's some great work on decisional authenticity, which is, there's even been work that, and I think it's important again to go back to that autonomy thing, is saying, we can recognize that a person with an eating disorder has mental capacity to make some types of decisions, while recognizing that perhaps for a decision that ends in the termination of their life, that in the throes of an eating disorder, when you're malnourished, it might not be the best time to be making that kind of decision. And there's been some work, again, as Catherine said, on decisional authenticity that's even called into question whether these, in terms of informed consent, when a person is severely depressed, whether because they are so devaluing of their own life, whether they can actually even give informed consent. And I think it was Eli that did that paper. But
so then we can,
yeah.
Thank you for taking the time to look at my diagram.
That's okay. Oh my goodness, we've gone over a little bit. Maybe did we have any questions come through? Maybe just take 5 minutes here for quick and fire questions.
Yes, Chelsea. The first question comes from Peter. It says, the use of palliative care is noted to be less than 50%. Can you comment on this and the use of palliative care for these people?
Would you like me to go, Catherine?
Sure.
Yeah, that's a great question, Peter, and I'm glad you asked. I think one of the things that's concerning to me is that assisted suicide and euthanasia are kind of being inserted almost as either they're being framed as a type of palliative care, or they are being used as a replacement to palliative care. I think the reality of severe eating disorders is that sometimes people do get to the end of their life through their eating disorder. I have seen patients, I have been a patient with multiple failing organs, and I feel very grateful that I'm alive today, but I know patients and I have worked with patients who are not. And that is exactly where we need palliative care. That is exactly where we need a care system that can hold people in those suffering, in that form of suffering, and also hold space. Palliative care does not necessarily mean the person is going to die. It means that we are focused on relieving suffering in those moments. So I think there's a great need for palliative care in eating disorders and across the board. And I have similar concerns that so few of these patients were offered that. Catherine, do you want to add to that?
No, that's good.
The next question comes from, it says, one of the earlier slides indicated California. I'm only aware of the Oregon and Colorado reported studies. Can you please comment on California?
I can. There is a paper that was published on proposing terminal anorexia as a diagnosis, and if you read that paper very, very carefully, there were 3 cases presented, and there were 2 that were prescribed MAID, and one of those was in California. The physician, I believe, the prescribing physician, I believe, was in Colorado. I'd have to read that paper more carefully, but one of the patients in that paper was in California. I did not find a report of that in California's report, and was unable to get verification from the stats office in California of what's contained in the other illnesses category.
That is all the questions we have in the chat, Chelsea.
Oh, we were so exceedingly clear. Is that the...
Yeah. Well, the last thing I'll just say before we sign off, and it was our last slide that I completely forgot to go to here. We have a series of these events coming up. We've got one on Wednesday with Anad looking at autonomy and eating disorders, and a few others coming up as well. It's probably not going to be the cleanest share. And we have published a joint statement. And if you have not signed it already, please do. If you agree with it, if you don't, absolutely fine. But we started with 40 leading experts and organizations when we published the study. And I'm pleased to say that since Wednesday, we have grown to over 200. So we appreciate you signing the statement, you reaching out to the organizations that you're involved with and asking them to sign the statement. If there's a logo that you don't see there on the top that you want to see, you have a voice. So reach out and ask, and sharing this with your colleagues. So we really appreciate your support. It doesn't feel like it means something, but it means something to be able to say, there's a joint statement signed by leading organizations.
And the piece that the treatable, not terminal, really speaks to the need for access to effective treatment, and that our attention should be focused on researching effective treatments, making sure everyone has access to effective treatments, no matter what their, how long they've had the illness, and that physicians be trained to recognize symptoms early so we can have early intervention. And there's just so many things when we think bringing the discussion back to like treatment and how we can impact patients' lives in that way.
Thank you all for being here. Thank you for your time. Bye.